So hi everyone, welcome to today's cross-team seminar. We've got three speakers lined up, really great lineup of topics that we're going to discuss. So we'll just have the speakers and then a few minutes for questions. So about 7 minutes presentation and 3 minutes question time. And then if we've got time at the end, kind of open up to wider questions. But Martina, I think, is online monitoring the chat. So if there's any questions, in the chat as well. So first up, we've got Sarah, and Sarah today is going to be talking about GALLANT, so Glasgow the GALLANT Lab, Accelerating Not Transformation. Got it sorted, thank you, Audrey. I don't know what happened all of a sudden, we were let in. Thank you though. Yeah, so I'll let Sarah. Thank you.
Yeah, that's fine. Yeah, thank you for grabbing for the tech. It's never easy, this kind of thing. So yeah, I actually thank you for the invitation to present. It's really nice to present work in front of colleagues, although saying that not many of your faces are that familiar. I recognise one or two. So yeah, my name's Sarah Lester. I am based here at the School of Health and Wellbeing, but I'm on this really large interdisciplinary programme of work, which I gave this really wordy long title to Marissa a month ago, and in the process of preparing this presentation, I realised I needed to hone it down for 7 minutes. So for this, I'm actually instead it's on the theme, but I've narrowed it down to look at the role that donor economics plays within GALLANT systems transformation efforts.
Sorry, Sarah, sorry to interrupt. We can't see the slides online for some reason. Would you mind sharing them?
Sorry, that's
Okay, thanks, Johnny.
Yeah, sorry, cheers to that.
You see them now?
I think they're loading. Oh yeah.
Sorry about that. That was my fault.
No worries, thanks.
There's no time to start again. Yeah. Okay. So my actual title, the role that donor economics plays in GALLANT systems transformation efforts. So as Marissa said, Glasgow has this is quite a wordy acronym, or could be called a backronym. I don't know whether it was made backwards, but it is Glasgow is a living lab accelerating novel transformation. It's essentially a partnership between the council and the university, but there's many other partner organisations involved in the work as well. So you see this kind of circle on the right-hand side there, the different solution-focused work packages, and then below them, these 3 work streams, and I'm based on that first one there on systems transformation.
Actually, we'll put it down the right-hand side, so
yeah. Can I put it over there, maybe?
You can just minimise it if you want.
If you click on the minus sign.
There we go.
Yeah, that one. You don't want to see anyone.
There we go.
Okay, you've gone online. Okay. The broad aim of GALLANT is to support a just transition which balances health equity and climate resilience at city scale. So that's a really brief overview, but just to give a kind of flavour of the size and the complexity of the programme. And so in terms of enabling conditions, kind of the things that preceded GALLANT that made it possible were so the establishment of the Centre for Sustainable Solutions, headed by Professor Jamie Toney. She's now the PI on GALLANT. During the COVID period, she was having these conversations with people very high up at the council, or a range of people, recovery-focused dialogues about what a climate-resilient, healthy Glasgow would look like, what the priorities were. At the same time, at the top there, as they were setting these really ambitious climate targets, carbon targets, there was the circular economy route map, which piqued the interest of C40 cities, who you might have heard of Amsterdam being the first city to adopt the donut. So that was like a pilot city, as was Portland and Philadelphia. And so C40 came along and said, approached Glasgow to be a pilot city and to create this thriving portrait using the donut economic methodology. So all these things lined up and were in place well before GALLANT was actually funded, but when it was successfully funded, that became a large part of the programme, especially for workstream 1, thinking about systems transformation and maximising the impact of this work. So there's me joining in November 2024. So a lot of that preceded me starting on this role. I began the stakeholder analysis of this whole GALLANT program in March 2025. So this was like a huge undertaking. Weirdly, I'm wearing the same T-shirt in that photo, but that was not intentional. So donut economics, are people familiar with donut economics, the framework? No? Okay, really quickly. So there's a lot of concepts, but I'm just going to kind of give you a whistle-stop thing about donut economics. This is Kate Raworth's framework, where she's taken the Sustainable Development Goals in this kind of dark green inner part of the donut. That's what everyone needs in order to be able to thrive. The outer ring is Rockstrom's planetary boundaries. I have noticed that ocean acidification is out of date because unfortunately that boundary has also been transgressed now. So apologies for the old image. Essentially, Kate Raworth wants us to be in that light green space. So that's the safe and just space for humanity. That's where you're balancing people and planet's health. And that's what we're aiming for. So I did the stakeholder analysis of this massive GALLANT program. I'm not going to talk about all of that today, which is why I've graded lots of bits of it out. The aims of this work were both practical to kind of feed into the program of work, make sure we were, focusing our efforts in the best possible way, and also academic to contribute to the literature on living labs and alternative economic paradigms. As I say, today I'm focusing on donut economics and the role that played. I conducted a qualitative process evaluation inspired by Harry Rutter and Elizabeth McGill's work on complex intervention evaluation within complex systems. I was conducting mainly one-on-one interviews because the range of stakeholders were vast and varied. In some cases, I managed to do this at a couple of time points, but real life is messy. It's very hard to do that in a very organised way. And I also, in some cases, did more like multiple, like maybe 2 or 3 people, kind of where that was relevant as well. I am a researcher on the GALLANT program, so I'm not professing to be this kind of outsider doing this work. Some of this did involve reflective learning along the way. So with my colleagues, after we would hold like a multi-stakeholder workshop, we reflect on that to help contextualize some of the knowledge through the document analysis and interviews. So why I think it's important to think about this transition, I've got 2 minutes left, so I might just kind of park that, but the rationale for doing this is that this transition itself is often very understudied, not really spoken about. There's lots about this kind of just and safe and just space, but very little written about how you achieve there and how you get there. Worldviews of change are vast and varied in relation to climate crisis and what you do to respond to that. In terms of what we found and the role of donut economics, there's this kind of, I get this concept of palatability. It's very politically acceptable in that it was something that the leader of the council could get behind because they are essentially, it's this really ambitious and positive vision of Glasgow. It's not something laying out all the faults and all the shortfalls. It's something that is to be aspired to. So that was really important for getting that buy-in at that political level. Time and time again, it comes up in the interviews that it's actually the social processes within these like interactive workshops where you're co-producing knowledge that's really important, because you're getting people within a space to talk about things that they wouldn't ordinarily talk about in front of people they don't necessarily have those types of conversation around, the donut kind of themes, really get to the root and unearth certain assumptions that wouldn't otherwise be kind of aired in those spaces. There's the role of kind of power being a really important part of that as well. This is policy mapping work, which kind of led on from the donut work, from the thriving portrait work. Some of the council members said what they saw when we took this holistic view is the dysfunctionality of their policy mapping, of their policy landscape. And so you can see there's all these things in tension with each other. And that is something which kind of was this light bulb moment of we actually are going to need to do things differently. So I am probably pretty much at the end of time, but just to say that there was this idea of the palatability of it almost being with donut economics, and this is like now linking to more international literature. it is something that local authorities have really taken hold of, even though the intention with Raworth's work was to change the way that economics was taught. It wasn't at all to change governance, but because they're democratically accountable to their local publics, it's something that can really take hold of local authorities in this way, which, I think there's a slight nuance here because it's seen as being impartial, but really there are many underlying values, which I am trying to get to with this analysis and this work. There's also this idea that donor economics itself can just solve these problems, but that is a huge misconception and a huge problem within the programme, because obviously it can only start to allow you to develop the work. It won't resolve everything itself. It's the start of the kind of conversation. And I will end there. I do have my references as well, but I just want to make sure I keep time.
Perfect. Great. Thanks, Sarah.
I know that's a lot for them.
Have any questions?
Similar to lots of other areas, have you seen pushback in the media or public discourse about donuts? Is it something?
Is it critiqued a lot? Do you mean?
No, more are you seeing press groups being very negative about it? I'm thinking there's huge amounts of negativity about renewable energy.
Oh, okay.
And are we seeing the same pushback against donuts?
Do you mean specifically in Glasgow, or do you mean more broad? I think donut economics, it's almost like it can be so much to so many people, it's hard to get really upset about donut economics itself, which is part of what I was talking about. Oh, it's palatable. It's something that people with very different worldviews can be like, oh yeah, because why would you have any issue with saying we don't want people in planet to thrive? Because it's nonsensical to have a problem with that in and of itself. It's when the details of it might start to play out that people would start to criticize it, I think. I mean, obviously, as a concept, people will always critique donut economics itself, but I think in terms of the Gallant work, no, they're more likely to pick up on there's much to complain about, don't get me wrong, but it would be more specifics of how things are done on the programme than using that as a framework.
Yeah, thanks for that. It's really interesting. Just kind of picking up on that, I was just wondering if you say a bit more about what the City Council are saying. So do they see it as a nice idea, or are they actually doing anything? Are they actually making changes to try and kind of fit their work around some of this? Maybe they're having practical impact.
I think that's what, if I'd have had more time, I'd have gone on to this, because it's a 5-year funded programme and we have an actual extra year of no cost extension. So relatively, this is a long period of funding, and what you start to see is in year 3 and year 4 there is more change starting to happen, because the relationships are developed to such a point where there is more trust, and you kind of see indicators that we've started to work on are making their way. They're being signed off, or they have already been signed off at committee, and now they're starting to kind of change the way that they measure things, or there's more collaboration happening through, say, innovation funding, and we have placements within the council, which should have perhaps been there earlier on, but things are starting to there is more tangible change. We're co-hosting an event next year with the council, and they're putting their input into it, and it is very much more of an equal partnership where it has waxed and waned for various reasons, but I think you start to see the real champions get more involved in the work from the council side of things, because they've had, when people are from a policy background and they're based at the university, things started to really flourish a lot better. Whereas if it's pure academic only at the university, that's where
We've got a question online from Tony. So, have you seen a disconnect between Glasgow City Council's build it and they will come very neoliberal view of big business benefiting the city and donut economics framework?
Well, that's a really good question. What's been, for me, one of the really interesting things is we did some work, the strategic projects part of the economic development team, and they are developing their next economic strategy, and they were genuinely very, very open to a lot of these ideas. I know it's one small part of the economic development team overall, but my presumption was this is going to land so badly, they're going to be really against it all. And then actually it did spark quite a lot of, we definitely need to change how we do our not consult engagement with different community groups. They've started to work with other parts of the council in different ways. So yeah, there was, I think what started to change is when people very high up in the council were part of those conversations, you could see this resistance of, no, GDP is still really important, and we might understand we might want to look at some other bits, whereas it depends on where they sit within the structure of the council. So yes, there are idiosyncrasies within the whole programme. Of course, not everyone's totally won over, but a lot more openness than I'd have thought, depending on the particular role within economic. If that answers your question, Tony.
Thumbs up. So yes, it does. Any final Louise?
Yeah, I was just going to say, obviously you've got the last year to go, and you've said a bit about that. Have you got plans to go on beyond that?
Yeah, there's the no-cost extension, which will take us to 2028, which is a massive relief in terms of, like, there's so much, not just on my stakeholder analysis, but there's all this data, there's all these things that we've been going out and doing, and it will give us more time to build on that, reflect, and, you know, there's coalitions that have formed which will far outlast the Gallant programme itself. So yeah, there's loads of ways of trying to make sure the right you know, legacy is put in place, especially with that extra. Yeah.
Well, thanks again, Sarah. That was a really interesting presentation. And next up we've got Peter. Let's make sure I share them this time. Today that is going to talk to us about Bayesian meta-analysis and epidemic modelling. A lot of words.
A lot of words. Thank you. Thanks very much. Thank you for the opportunity to speak. I'm Peter MacPherson. I'm Professor of Global Public Health here. I work in the Public Health unit. And yeah, we're going to be talking about TB. This is leading out of a paper that's just been published a couple of weeks ago. This has been a really nice, fun bit of work. I've learned a lot on this project, and some cool new methods that hopefully are relevant to lots of people. And I realize there's a lot in here. You can see by the title. So you know, if you're confused, that just means that you're listening carefully. Okay, good. So we're going to be talking about tuberculosis. We see very little TB here in Scotland. About 200-300 people a year get sick with TB in Scotland. Across the world, more than 10 million people become sick with TB each year. More than 1 million people die every year. In fact, it's the leading infectious cause of death worldwide and massively under-researched. And there's huge disparities in tuberculosis epidemiology at national level. So you can see the darker green countries are where there are the highest incidence of TB disease in the world. So you can see Southern Africa, Southeast Asia, and also some areas that you might not expect, such as in the former Yugoslavian and Russian republics as well, where we have large outbreaks of drug resistance. So huge disparities at global level. And I was writing a commentary piece about where we should screen people for TB, and I somewhat naively wrote in that paper, there are more people with TB in cities than there are in rural areas. And I actually thought, wait a minute, we actually have got no data to tell us whether there are more people with TB in cities than in rural areas. And it sort of makes sense, because we know that the world is rapidly urbanizing. By 2050, 70% of all people will live in a city. So you can see in the graph the trends in rural population and urban populations over time. And that's up to 2025. And you can see in this heat map in Africa, you know, many of the areas that I work in Malawi and in Kenya and Uganda, you know, you've got these dense, you know, mega cities emerging now. And of course, in Asia, this transition happened 20, 30, 40 years ago as well. So the world is really rapidly urbanizing. And in urban settings, as well as in rural settings, there are, you know, key determinants of tuberculosis. So crowding, if you've got more people crowded together, there's more TB spread. If you can access healthcare, then you're more likely to be diagnosed with TB, maybe diagnosed earlier. Where there's lots of poverty, maybe rural poverty or urban poverty, that is a key facilitator for TB. Undernutrition is a key risk factor as well. Air quality, both indoor and outdoor air quality, HIV prevalence, and smoking as well. And just to take one example, India, the most populous country in the world, 72% of the population in India live in rural areas, but only 40% of health workers are currently stationed there. These determinants of TB are systematically different between urban and rural areas. So we aimed to compare urban and rural TB prevalence within low and middle income countries and WHO regions to inform targeted resource allocation and public health approaches to TB elimination. So can we allocate our resources within countries more efficiently? So what is a TB prevalence survey? Well, TB, although we said a lot of people die from it, it's actually quite rare at the population level, and our sources of data about it are quite biased as well. If we rely on notification data, waiting till people come into a clinic, we get a really biased picture of how much TB there is, because that's biased by healthcare seeking and reporting and all other sorts of things. So what we really want to do is to do a prevalence survey, where we go out and systematically and randomly sample people within the community, offer them testing for TB, and then estimate how much TB there is in the world. And the WHO has sponsored about 25, 26 national TB prevalence surveys in priority countries over the last nearly 20 years or so. Unfortunately, they've all been cut now because Donald Trump has pulled all funding for national TB prevalence. So we, in this project, recognize that data is actually relatively sparse, and we would have very few estimates of prevalence for any particular country and at any particular time point. So we decided to use Bayesian meta-analysis methods, and these naturally lead to hierarchical models and multi-level models where study-specific effects are modeled as arising from a shared population distribution. And essentially, we're borrowing information across studies, allowing estimates that are small or noisy to benefit, to borrow strength from the full evidence base. And that includes partial pooling. So it really shrinks the most extreme study estimates towards the overall mean in proportion to their uncertainty. And I'll show you what that means. So we started off with a systematic review where we looked for TB prevalence surveys in low and middle income countries from 1993 to 2024, searched national and subnational surveys in English, French, Spanish, and Portuguese. And after screening over 10,000 abstracts, we identified 47 prevalence surveys from 27 countries. That included about 2.5 million people being screened for TB, of whom only 7,509 actually had confirmed TB disease. And 40% of those were in urban areas and 60% a huge amount of work to only find 7,500 data points, essentially. And we constructed a Bayesian regression model. There's a lot behind this, so I'm not going to go into too much, but to kind of explain what we're doing, we're basically modeling the log odds of TB prevalence, comparing urban to rural areas. Well, that's our estimate. And we weight each study by its precision. So how precise is that estimate of prevalence within each survey? We also have random intercepts, so that allows for each study to have its own intercept, but also for studies to be nested within countries. So for example, maybe South Africa's got more than one study, we allow those data to be correlated as well. And then we have random slopes. That basically means we allow the effective time to vary between countries as well. And then we have priors in each parameter. And these are basically weakly regulating priors that allow us to just gently point things in the right direction so we don't get ridiculous estimates, odds ratios of 100 or anything like that. So this is kind of our main sort of result here. It's essentially a forest plot split out by WHO region. You have the African countries, countries from the Middle Eastern region, the Southeast Asian region, and then the WHO Western Pacific region. And you can see there's a lot in here. The green dots are the empirical estimates, and the black dots and lines are our model, our estimates from our random effects Bayesian model. And so what you can see is averaged over the study period, and this is important, in Africa, there appears to be more TB in urban areas than rural areas. In the Southeast Asia and the Western Pacific, there is more TB in rural areas compared to urban areas. And we don't really have enough data to say much about the Eastern and North African region. However, when we look at the effect of time, we see that overall, the urban to rural prevalence ratio is rapidly widening. And that means, when we're above 1, there's more TB in urban areas. Okay, and each of these points is a single prevalence survey estimate. So by 2024, the posterior probability that there is more TB in urban areas compared to rural areas is 96.6%. Because we have this partial pooling and multiple and random effects with studies nested within countries, we can look at the time trends within specific countries as well. And you can see, although these look relatively similar, there's actually a few nuances. First thing to say is some countries are urbanizing their TB epidemic much more rapidly than others, and some started at a much earlier phase as well. So, for example, if you take the Gambia, already back in 2000, the year 2000, probably most TB in the Gambia was urban, and by the time we're up at 2025, there's a big, nearly all of TB. We're pretty certain that nearly all of TB is urban. And you can compare that, for example, to India, which started its transition to an urban epidemic much later than the Gambia, and is just beginning to catch up now. But the trajectory is very, very similar in all countries. And then we basically combine those posterior estimates of the distribution of TB in urban and rural areas each year by estimates of TB incidence, by how much TB we find, the case detection, and by population growth as well as some assumptions around the duration of infectiousness. And we're able to do this because we can propagate uncertainty correctly through all stages of our Bayesian model. And what that allows us to do is to estimate how much TB there is in each of these urban and rural countries, in each of these countries by urban and rural area. And again, you can see the patterns quite clearly about where some countries, Gambia that we noted before. And so these are the numbers or the percentage of people with TB within each country as well. So Gambia are really rapidly urbanizing. Some of that's going to be driven by population shift, and some of it is going to be driven by change in the epidemic as well. And again, it's quite interesting to look and see where the changeover point from a predominantly urban to a predominantly rural epidemic is for different countries. So you can see this publication here. It came out in PLOS Medicine a couple of weeks ago. And we were able to use really quite exciting modern methods to combine similar evidence, but to get more precise estimates. That's through partial pooling, incorporating prior distributions, and propagating our uncertainty correctly as well. And it allows us to make probabilistic statements about what we think is happening about TB epidemics, and allows us to answer really interesting questions that you would struggle to do within a conventional frequentist model. If you're interested, there's a cool new book out, Bayesian meta-analysis, and also encourage anybody to great video series on YouTube called Statistical Rethinking, all about Bayesian approaches to modeling. So, yeah, thank you, and happy to take any questions.
Great, thanks, Peter. Any questions?
Yeah, why this study did not include countries like Peru or Bolivia?
Great point. So we actually searched for them. You saw that our search terms were in Spanish as well. Unfortunately, there have been no national or subnational prevalence surveys that have been done in those countries. And which is a huge continent, and there is no data from there. TB is a neglected disease.
Thanks, Peter. Thanks for the book recommendation. That's my birthday book list. So
or you can get it in the library for free now.
I'll be first in the queue. It's a kind of bigger question. The study is really interesting, but just you mentioned Trump's cuts and how that's impacting on how you measure this. Are there projections about what those kind of cuts to international aid are going to do to TB itself in a lot of these countries?
Yes, essentially there's been a couple of papers that have come out in the last few months. These are always really uncertain because your counterfactual has to be essentially, what's happening now versus what's likely to happen, and both of those have got a lot of uncertainty around them. However, we're anticipating hundreds of thousands of additional deaths over the next 10 years or so due to TB and many other priority diseases because of those cuts. But we're hoping that other funding sources might come in and mitigate some of that.
Cool. That's great. Thanks so much again.
Cheers.
Thank you. Stop share again. Much tech. Next up we have These are yours.
Yep,
That's perfect. I always like to make sure I've got the right one. So, third and final presenter is Louise, and today she's going to talk about preschool health and development outcomes following prenatal opioid exposure.
On to another subject negatively impacted by Trump. So fortunately, not so much here. So my name is Louise Marryat. I'm fairly new in the school. I just joined in January. So I thought I'd come along and tell you a bit about what we're doing. These are very early findings, so we very much welcome any feedback anyone has on them. I'll give you a wee bit of background because I didn't know quite who was going to be in the room and online. So I'll tell you a bit about opioid use in Scotland first. So you've quite likely seen in the news a lot about this real increase in opioid use, and particularly affecting North America. So we've seen a huge rise in levels of opioid use and changes in the types of opioids as well. So in many countries, we've seen huge increases in things like fentanyl use and a lot around prescription opioids as well. Things look slightly different in Scotland. Actually, in Scotland, our estimate, and it is always estimate because a lot of it's illicit, is our estimates of opioid use are pretty stable. So we reckon around 47,000 people are dependent on opioids in Scotland. And that's relatively stable, as you can see here. More men than women dependent on opioids. We're also seeing an ageing population of people using opioids as well. We think about 2/3 of people who are dependent on opioids are on medication-assisted treatment. So that's mainly methadone in Scotland, a bit of buprenorphine in the mix as well, and that does vary from country to country. Scotland, as you probably also know, sadly has the title of the highest level of drug-related deaths in Europe, and 80% of those deaths involve opioids. But importantly, the latest data we have on this is from 2019 to 2020, and we know that 602 children lost a parent to a drug-related death in there. So it doesn't just affect the people themselves, has much wider impacts, and that's what we're interested in. We know that there's a lot of women that do use opioids in pregnancy. Before this project started, we didn't know quite what that looked like in Scotland. And we know that women who are using heroin or other illicit opioids are normally encouraged to stabilise on medication-assisted treatment when they become pregnant, if they're not already on that. It's a bit of a mix. It's a postcode lottery of care for these women in pregnancy. So some areas like Glasgow have quite intensive support. So through the Blossom service, that was called SNPs, they've recently changed their name. And women get a lot of intensive support. But it looks different in different areas. And as I say, it's postcode lottery, so a lot of women don't receive any additional support as well. We did some qualitative interviews around the services in urban areas that you can see on the link there. I'm really interested in what happens to the children that are exposed to opioids in pregnancy and what happens in their long term. So this is the basis for this project. We started this by doing an umbrella review of reviews, so a review of reviews of the impact of exposure to opioids in pregnancy on preschool developmental outcomes. So we found there was like reviews looking at visual outcomes, there were reviews looking at cognitive outcomes, and we tried to bring those all together. We found 11 reviews, which comprised just under 500 papers. Wasn't a huge amount of overlap, interestingly, between those. And what we found, there was that evidence indicated an association between exposure to illicit opioids or medication-assisted treatment and challenges for preschool children with vision, with motor skills, so both gross and fine motor skills, with externalizing behaviours, so things like hyperactivity, and with language difficulties as well. But all other domains, including things like cognitive difficulties, internalizing symptoms, so that's things like depression, were all inconclusive. But actually, most of the evidence wasn't robust. So a lot of the evidence comes from very small studies, mainly clinical samples that follow up women that have been in individual clinics over time. So you're lacking the numbers to look at things in depth. But also, we know with this population, everything's complicated by environment. So we know that children who are living in poverty are more likely to have difficulties in a lot of these domains. And it's really hard to disentangle that. And that's some of what we're trying to work towards in the opioid in pregnancy study. So I'm just going to tell you about a tiny little bit of the analysis for this, and I'm happy to answer questions on the wider study later. So for this, we wanted to look at the impact of exposure to prenatally to exposure on opioids on development in the preschool period. So we started off by examining the incidence of prenatal opioid exposure in Scotland over a 10-year period, and so between 2009 and 2019. That was initially to give us the time for children to get their outcomes so that we have the outcome data, and then to look at this association. And we're going to go on to do some causal inference work later, but we're still in the process of doing that at the moment. And to do this, we used administrative data, so from health records, we're building on education records and social work records as well, but mostly health records at the moment. So we had to identify our opioid exposure in pregnancy, and we have two groups of children within that. We have a group of children who are exposed to either illicit opioids or medication-assisted treatment. We have another group of kids that are exposed to analgesic opioids, and you'll see a bit later they look a bit different. Their demographics are quite different. That was all based on prescription data. And then we have a demographic control group that are matched to our main control group. To sort of look at those differences in levels of deprivation. And we have a whole range of outcome data, which we are starting to look at. I'm just going to tell you about some of the 27 to 30 month check here. So in terms of identification, and I'll go through this quite quickly because I don't have much time, we didn't know how many women would have told their midwife that they were using opioids in pregnancy. So we had no idea what this would look like, but actually about 80% of women who use opioids in pregnancy had informed their midwife. We also picked up women, and obviously you can fall into more than one of these categories, through birth records. So that's mainly neonatal abstinence syndrome, or there's a code for opioid exposure as well on those. Through women being admitted to psychiatric hospital or general hospital admission, hospitals in pregnancy, through prescription data obviously from methadone and buprenorphine, and through the drug and alcohol service data as well. So we've got just under 5,000, to get the box off, just under 5,000 children in that group, another 5,000 identified in the analgesic group, and we've got just over 14,000 in our controls. And this is what we found in terms of the levels of opioid exposure. So we thought that we'd see this slight decrease in our main cohort of opioid exposure over time in that illicit and medication-assisted treatment group. But what we didn't know that we'd find was this increase in the opposite direction in our analgesic cohort, levelling off at about 2014, which is when some sign guidelines came in about prescribing opioids in general in the population, and we saw a levelling off. So that very much mirrors the population level data as well. I'm going to skip through these because I don't have much time. We saw, in terms of birth outcomes, we saw similar patterns to what had been described in other studies. So having more likely to be having low birth weight in our main cohort, more likely to be premature, and being smaller and having smaller head circumference. And that holds true when you look only at term babies. These babies are still likely to be smaller, even when you limit that. They're also sadly more likely to die in the first year of life, our group, and they're more likely to be placed outside of their mother's care at discharge from hospital as well. And you see the analgesic group sort of fall in the middle of those two groups. And we see the same pattern basically when we look at developmental outcomes as well. So what we see in the dark bar is that generally across all the different domains that are measured, so this is through the 27 to 30 month health visiting review, uses the ages and stages questionnaire. And really across every domain that we look at, the children in our main cohort, so they're being exposed to heroin, methadone or buprenorphine, have the highest level of difficulties. Then our analgesic cohort that have a similar sort of exposure, but are demographically quite different. And then our demographic controls having the lowest level of difficulties. And where we have population level data, I've added that in. So the population is obviously more affluent overall. So a slight difference there. One of the huge differences, though, is in vision. And actually, this is where we have the strongest evidence so far, is around visual difficulties. So those were just binary, but actually we see the same patterns when we add in some competing exposures there. So we looked at sex of child, alcohol consumption, smoking in pregnancy, and we see similar patterns, but actually that gap between our two cohorts closes somewhat, apart from in vision, which still really stands out. And some of the work that's been done looks like it's specifically around methadone exposure in that group as well. And I think I'm out of time. The vision tracks basically to the preschool screening as well, so we still see the same pattern at age 4. So that's something we are talking to colleagues who work around vision outcomes about whether we should in Scotland be putting in an earlier vision screening for this group of children. So what we found so far is that opioid exposure in pregnancy was associated with a whole range of developmental outcomes, which really supports the existing sort of quite tentative evidence, but it also extends that to some domains where we didn't have such robust evidence before. As I said, we're moving on now to look at more causal inference techniques to try and work out if there's particular impacts of different types of opioids on different outcomes. So that's what we're working on at the moment. So watch this space. There are a range of limitations. So things like alcohol, we know is poorly recorded. Women don't report it accurately. Well, no one reports it accurately, we know. But it's not reported accurately within the data. We're lacking some data that we'd really like on some particular prescription exposures at the moment. And mental health data is really lacking because we don't have GP data in this as well. So we have some data from prescriptions, but we can't tell how women are at the time we know if they have a prescription or not. We also don't know if or who is missing, and this is something that we've talked about a lot as a group. Is especially it's quite challenging to work out who's missing from your population. Our gut feeling is that we probably capture most women on the illicit side, but it's probably the analgesic side that we're actually missing, because a lot of those women could have over-the-counter prescriptions, whereas we reckon we probably detect most of our other women within the sample, but we'll never know. And we've not yet broken down by the different types of opioids. So there's a huge range of people involved in this. So thank you to all of them. And I'm happy to take any questions or later if people want to follow up.
Thanks, Louise. That was a great presentation. Any questions?
Yep. Please. Great. I just wanted to check a number basically when you reported the infant mortality. Seemed to be that in the main comparison cohort about 1%, surprisingly high to me. Just checking why that might be.
Yeah, we know that 1%, and it's compared to in the population is about 0.3%. So it's a big difference. Oh, sorry.
No, I think it was the other way around. I think the main cohort, the non-exposed cohort.
No, I think it was the
1%.
The 1% is the exposed cohort. Yeah.
So I guess what I'm getting to is the number of childhood deaths is small. And if you've only got 5,000 kids in that group,
yes,
I was surprised it's such high as that, even at the high risk.
Yeah, we don't have. I think I'm looking at Shona is a new PhD student as well. She's a third-year PhD student, but she moved to Glasgow, and Shona's looking at mother's outcomes. So that's why I'm looking at Shona. But I think we don't I think we don't have cause of death for the children, do we?
No.
Because we thought the numbers would be too small and because it's such sensitive data. But what we can see in that group is that they die at a later stage. So they're less likely to die in the neonatal period. They're more likely to die towards the end of the first year and the second half of that. So we need to do a bit more digging. We're about to get a whole load of new data and we're extending our births up to 2026, 27. So we'll have a lot more and we might be able to look in a bit more detail at that. We are asking for cause of death. We'll see if we get it. But that might give us a few more clues.
It's not prematurity, it's the cause, because it was actually the genetic group that had the larger portion of earlier preterm, whereas it was sort of later preterm, which is what you'd expect, but they'll not really be based on poison.
Yeah.
So it can't just be put down to the prematurity really either.
Yeah.
We've got a question online from Ruth. Very interesting presentation. Have you considered using capture, recapture methods to try and estimate?
That is something we've talked to our statistician about, but we haven't done yet. So yeah, there are various ways of trying to work out who's missing. It's really tricky. We found it really hard. At the moment, we've been visually mapping everything. So we haven't statistically tried to look at who's missing in our data, but we have been visually mapping out. So we have a DAG, a directed acyclic graph of missingness in our data, which was really complicated to work out. And we are hoping to take that to stakeholders to sort of check out with them as well. So we're trying to take a mixture of approaches to working this out. But yeah.
Got another question online, if that's okay. From Tony, with the increase in synthetic opioids being used to mix with other traditional drugs, will it be possible to assess this in the future? Data are just too hard to measure. We don't really know what substances there are.
Yeah, that's a good question, because we know that a lot of people don't know what they're taking at the moment. So yeah, it might be. I mean, it's obviously easier when you're looking at prescription opioids, because we do have a better sense of what people are using. In terms of the illicit substances, it's tricky, both because people don't know what they're using, but also the data capture is always behind. So the women, and particularly the pregnancy data, women get presented with a list of substances, and so anything novel, it just isn't included. So even if people do know what they're using, it's not always captured well. So yeah, it is a risk with these data, and there's a huge amount of polydrug use as well in this cohort. Great excitement from outside the room.
Any further questions? Well, thanks again to all our speakers today. It's been really great. I'm sure you can agree it's been a diverse and interesting set of presentations. So thanks again for volunteering. We are always looking for volunteers. If anyone is interested in taking part in the seminar series, please contact myself. But thank you again. We finished a wee bit early, so I'll let you all go off and get your lunch. Thanks everyone online.
Thank you very much.